Okay, so let's continue with our series of ovarian tumors. We have already discussed different ovarian tumors related questions. So let's start with another question. A 62-year-old woman with a family history of breast ovarian cancer has a high-grade serous ovarian carcinoma. Which molecular alteration are most likely present? So high grade, we have already discussed different molecular alterations in different ovarian tumors in the first part of this series. So high grade is TP53 and BRCA1/2 mutation, because it is also relevant family history. We know KRAS and BRAF is associated with low grade. We have already covered this part. CTNNB1 and PTEN mutations, these are specific for endometrioid carcinoma, and ARID1A and PIK3CA mutations are specific for clear cell carcinoma. Now let's do another question. A 40-year-old woman with long-standing endometriosis develops an ovarian tumor. IHC shows napsin A and SNF1 beta positive. Most likely associated mutation are. So we have a history of endometriosis, which is commonly seen in case of clear cell as well as in case of endometrioid carcinoma. And IHC napsin is specific for clear cell carcinoma. Also SNF1 beta is specific for clear cell. So the likely answer is option B, that is PTEN and PIK3CA. We have already discussed other molecular mutations prior to this question. Now let's do another question. A 35-year-old woman with Peutz-Jeghers has bilateral ovarian tumors showing intratubular hyalinizing Sertoli cell morphology. The most likely diagnosis in this case is sctat tumor with annular tubules. So these tumors are often associated with Peutz-Jeghers, and also there is presence of eosinophilic hyalinizing secretion, which is palisaded by six cord cells, and these are often positive for inhibin, calretinin, which is similar to that of granulosa cell tumors, but these are FOXL2 negative, whereas granulosa cell tumors are FOXL2 positive. So since it is associated with Peutz-Jeghers, we can also say that there is involvement of stock mutation, the stock 11 mutation. So let's go through another questions. A 50-year-old woman presents with virilization and ovarian tumor with Rinke crystals. Most likely diagnosis is. So this is another outright question, which points us towards the leydig cell tumor. So here features of virilization is seen due to androgen secretion, and often it involves the hilum of the ovary. Let's do another question. A 60-year-old woman has an ovarian tumor with microfollicles that is called external bodies. So it points towards granulosa cell tumor. Nuclear grooving, that is typical coffee bean nucleus, and FOXL2 mutation. Most likely diagnosis is adult granulosa cell tumor. Now in case of juvenile granulosa cell tumor, it lacks the FOXL2 mutation, and also the nuclear grooving is absent, and it shows follicles with luteinization with higher atypical mitosis. Now let's do the final question of the day. A 25-year-old woman with unilateral ovarian tumor shows seeds of luteinized cells, marked nuclear atypia, high mitotic rate. IHC is inhibin positive and melan A positive. So the most likely diagnosis in this case is. So these are all markers of steroidogenic markers. So it hints us towards steroid cell tumor.